Hello, not audible.
Hi, Dr. Shalini.
Yeah, now it is.
Hi, Ritu.
Hi, Shalini.
Hi.
How are you?
Hi.
Nice
Fine.
to see you.
Long time no see.
Yeah. It happens.
Shall we start? It's already like 10 minutes
I
later.
think it's 3:10, Shalini is there. Shalini?
Hello.
Hi, Shalini.
Hello, Ritu, and good evening, Anuradha ma'am, and good evening, Sulekha ma'am. Good
Hello,
evening,
Miss
everyone, all who have joined.
Yeah.
A very good evening to everyone.
Good evening.
I think we should, since
Yeah.
Dr. Sharmila has also joined, our first speaker, I think now we should start our program. Hello,
Yeah, yes,
Dr.
please.
Sharmila?
Yeah, I'm ready.
Yeah, we
Yeah,
can.
you're the first speaker. So shall we start?
Yeah, please.
So, good evening, everyone. On behalf of Varanasi Obstetrics and Gynae Society, I welcome you all. Today, we all are having a very interesting webinar, which is in association with our own FOXY, and it is on respectful abortion care. Our first speaker is Dr. Sharmila Avayu, and she will be speaking on Medical Termination Amendment Act 2021. So for this, I would like to invite our chairpersons. First of all, I would like to invite our esteemed Dr. Anuradha Khanna ma'am, who is the patron of our society, as well as she is president of UPCOG at present. I welcome you, Anuradha ma'am, on the chair. Next, I would like to invite Dr. Sudha Singh ma'am. I think she has not yet joined. I would like to invite Dr. Lavina Chaube, president, a very dynamic and diligent president of Varanasi Obstetrics and Gynae Society, to chair this session, and Dr. Sangeeta Roy, an eminent gynecologist, and Dr. Aarti Divya, also an eminent gynecologist of Varanasi, who is also working on cancer, female cancers. So now may I request Dr. Lavina Chaube to please read the CV of our first speaker, Dr. Sharmila Avayu. And may I request Dr. Shriman to please share the CV of Dr. Sharmila on the slide. Thank you so much.
Thank you, Dr. Shalini. Can you hear me?
Yes.
Yes, okay. So Dr. Sharmila is MD DGO DFP, FICOG and PGDCR. She's the vice president elect for FOXY 2024. She was the chairperson of Clinical Research Committee FOXY 2016 to 18. She was one of the ICOG Governing Council members from 2021 to 23, National Coordinator UNICEF FOXY PCA, National Coordinator MEDHA FOXY PG Program, National Coordinator ISAR Gurukul 2022, WHO Sierra MD SR India member, past Secretary Trichy OG Society, President Menstrual Hygiene Management Consortium 2018 to 20, and Joint Secretary Justosis India Association. So that's a very heavy CV. And we love to have you here with us, Dr. Charmila, and we would really like to hear what you have to say. Thank you. So I welcome you.
Thank you so much, Dr. Lavina. Thank you so much for that kind introduction and for chairing the session. Respected Anuradha Khanna ma'am, thank you so much for inviting me. Respected the Secretary of the Society, Dr. Shalini Tandon, and dear Ritu, thank you so much for the invitation to Varanasi Society. Let me start my talk on this very important topic, and that is the amendments to the MTP Act, which we have been having for so many years, but the amendments which have happened are really useful. It's going to be helpful to women's health, particularly in the lower socioeconomic status, because we see that the awareness is less about abortions, and still septic abortions form a big part of the maternal mortality rate in the country. So what are the new laws and what are the changes in the rules which has happened recently? And we need to know that unsafe abortions are quite common in India in spite of such a liberal MTP law. And it leads to mortality, morbidity, and it hampers women and girls' full participation in the life events. There is almost like an 8% reason for abortion, maternal deaths due to abortions. And that's the third leading cause. And nearly 2 out of the 3 abortions are being performed in a country are still unsafe. And then pregnancy-related deaths happens in women and girls who are under age 24. So according to the WHO, when is abortion considered safe? It needs to be done by appropriate methods and by trained personnel. Otherwise, it is less safe or unsafe, even if one of the criteria is not met when an abortion service is being provided by a service provider. And what is the amendment which has happened in 2021, which has offered a safe and comprehensive care further to the law? The previous act actually said there's a need for one provider for MTP up to 12 weeks. But now it's been amended to up to 20 weeks of pregnancy. The opinion of one registered medical practitioner is quite enough. You don't need 2 providers to give an opinion, which was in the previous act, and that is between 12 to 20 weeks, we needed to have the opinion of a second provider so that we can go with an abortion. But now, up to 20 weeks of gestation, one practitioner who gives an opinion that there's a need for a termination of pregnancy is quite enough. And the requirement for 2 registered practitioners will be happening only when there's a pregnancy between 20 to 24 weeks of gestation. So the potential of this amendment to the law will cause an increase in the number of facilities, especially in the public sector like PHCs. There will be only one provider who is giving the abortion services. And this may have more women coming forward to have their abortions in a safe place. And in the previous act, you can do an MTP only when it's immediately necessary to save the life of the women when the gestation age is more than 20 weeks. But now it has been enhanced, and that enhancement is for 20 to 24 weeks of pregnancy. But please remember, it is not a blanket agreement that you can do for abortion for any person who walks in. It's only for the special or the vulnerable categories of women. And as far as birth defects are concerned, and those which are not compatible with life, any gestational age is okay with the amendment now, and that we need to do with the consensus of the medical board. And the outcome of this is the potential. What will be the implication of this is it will cause an increased access for the vulnerable women to safe and legal abortion services. And this has been defined by the rules committee, and that will include violence victims, minors, among others. So the previous actually had the termination of pregnancy only for 20 weeks. But now, when there's a congenital anomaly or a birth defect which is incompatible with life, you can do an abortion at whatever gestational age it is, you have diagnosed the baby to be having, but it has to be done with the help of a medical board. You cannot do it. You need to have the medical board's concurrence for gestational ages beyond 24 weeks for termination for birth defects and congenital anomalies. And the implication of this is, this will also increase an access to safe and legal abortion services for women who have a baby which has been diagnosed to have birth defects and congenital anomalies and is diagnosed quite late. And the other thing, the amendment which has happened is, the previous act said that a lady who has got a contraceptive failure needs to be a married lady. But now it has been extended to any woman of a partner who is having a pregnancy which is because of a contraceptive failure, and she can undergo an abortion. And this will also increase the access to safe and legal abortions for any lady, irrespective of her marriage. Especially with an upcoming changes in the legal age of marriage, this amendment is going to be very, very important in increasing the access to safe abortion services. And the previous act said that information should not be disclosed except under authority of law. But now they've made it clear the name of the lady should not be informed. Any other particular of the patient should not be informed to anybody who's asking about information regarding the abortion. And you can reveal it only when you're authorized by law at the time being enforced, because you cannot give the name or other particulars to any relative who walks in asking about details about the abortion. You need to be extremely careful about that. And this will increase the privacy and confidentiality of the abortion seekers, and probably will increase the demand, but will need to safeguard the rights and dignity of a lady and provide a respectful, bias-free service, which should include counseling and contraception. And this law prioritizes confidentiality and safety. Name and other particulars of a lady who's asking abortion needs to be very confidential, and you can disclose it only when there's a person authorized by law and is asking for information. And the ground for failure of contraception has been extended from being only for married women to also to women who are in live-in relationships. And what are the other amendments which has happened? And we have to be very clear about this, because when you have a pregnancy between 20 to 24 weeks, do not think you can do abortions for people who come below 20 weeks. There's a special category for whom you can offer the services between 20 to 24 weeks. And the norms for the registered medical practitioners, which were in existence in the earlier act, has been amended and has been made more liberal now. And the medical board, which is formed, the powers and functions have been elaborated. And the medical board, there's a need for one obstetrician, one pediatrician, and possibly a radiologist when available. And this has to be formed by every state, and it needs to provide timely evidence-based decisions which can change over time. So what are the special category of ladies for whom you can offer these abortion services between 20 to 24 weeks of gestation? And that is survivors of sexual assault, rape or incest. And suppose there's been a humanitarian setting, like what happened in Gujarat now. Suppose there's a lady who seeks an abortion because she's been involved in that tragedy. Probably you need to offer, even if she's between 20 to 24 weeks of pregnancy. Suppose there's a change in her marital status during the pregnancy. Suppose her husband has passed away or she's divorced and she wants an abortion. You can offer it between 20 to 24 weeks of pregnancies. Ladies with physical disabilities, but the criteria needs to be defined under the Disability Act. You cannot do it just for any minor disability. Mentally ill women, including mental retardation women, when they come in the late pregnancy between 20 to 24 weeks, you can offer the services. Minors, that is girls below age 18, can be offered abortion between 20 to 24 weeks. And suppose a fetal malformation has been diagnosed quite late, and there's a substantial risk of the baby having a life which is incompatible with life, and can suffer from physical or mental abnormalities to be seriously handicapped, you can offer the abortion services. And this, I'm making it very clear, between 20 to 24 weeks, any of the 7 criteria needs to be met before you go in with an abortion service. Suppose nothing is met, you may need to ask her to go to the medical board, get an opinion that she needs an abortion before you can do. Otherwise, please do not do between 20 to 24 weeks if any of the 7 criteria is not being met. And what about the criteria for the registered medical practitioner, which has changed now? Initially in the old act, it said any practitioner was assisted in 25 cases of a procedure of MTP and has done at least 5 independently, is eligible to do a service, or has completed 6 months of house surgency in the field of obstetrics and gynecology, a practitioner who holds a postgraduate degree or diploma on obstetrics and gynecology, or somebody who's got an experience of at least 1 year in the practice of obstetrics and gynecology, can do an abortion service. But now there are certain criteria which has been increased also. And according to that, suppose a person wants to do an abortion within 9 weeks of pregnancy with only drugs, medical methods, this person can do it only with an experience of 3 months in the Department of Obstetrics and Gynecology at any recognized hospital, and should have been trained to perform at least 10 cases of MTP by drugs, the medical methods, under the supervision of a registered medical practitioner who's in a hospital established or maintained or a training institute approved for this purpose by the government. Then they can do medical methods of abortion up to 9 weeks of gestation. And these are the norms which has been said earlier, and to that they've added this, that is experience at any hospital of 3 months in the practice of obstetrics and gynecology, or has independently performed 10 cases of MTP by medical methods under the supervision of a registered medical practitioner. They can do it up to 9 weeks of pregnancy, but the old criteria stands for the other group, that is 25 cases they should have assisted, and they should have done at least 5 independently, or they should hold a degree or a diploma in obstetrics and gynecology, or should have done 6 months of house surgeon post in obstetrics and gynecology, or somebody has done 1 year in the practice of obstetrics and gynecology. Any of this group can do a abortion service. So till 12 weeks, that up to 9 weeks, you had the addition of people who are not so experienced, but still can perform a medical method. But for up to 12 weeks, the old criteria stands. That is, they should have done at least 25 cases assisted and done 5 independently, PG degree or diploma, 6 months of house surgency, or 1 year of practice in OG. For 12 weeks to 20 weeks, 3 criteria stands. In the previous one, you had 4. That is, you had the person who assisted in the performance of 25 cases, but when you want to do for between 12 to 20 weeks, they need to hold a degree or diploma in obstetrics and gynecology, 6 months of house surgency post, or 1 year of practice in obstetrics and gynecology. For 12 to 20 weeks, the criteria becomes more stringent. And regarding between 20 to 24 weeks for that special category, the 7 criteria, here also it's very stringent. They need to hold a degree or diploma, or should have done a 6 months post in obstetrics and gynecology as a house surgeon, or they should have worked for 1 year in the practice of obstetrics and gynecology. What about beyond 24 weeks, when the medical board says you can go ahead with the termination? Only two criteria are there for the RMP. That is, they have to hold a postgraduate degree or diploma in obstetrics and gynecology, and they should have worked for not less than 1 year in the practice of obstetrics and gynecology. That is, for pregnancies beyond 24 weeks, the experience in training becomes more stringent. So what about the medical boards? They will have a gynecologist, a pediatrician definitely, and if available, there will be a radiologist or sonologist in the medical board. And this medical board is for termination of pregnancies beyond 24 weeks of gestation. And the board needs to ensure that the procedure should be safe for the lady at that gestational age, and whether the fetal malformation will cause a substantial risk of the baby having an incompatible life, or the child will, if it's born, will suffer from physical or mental abnormalities to be seriously handicapped. So they have to be very stringent in checking for all this before they can say that we can go ahead with an abortion beyond 24 weeks of gestation. And they can ask for other specialists on the board, ask for further investigations before deciding on the termination of pregnancy. And the FOXI, with the guidance of the ministry and WHO, will support as part of the program the hosting of medical board information on the websites. And medical board will examine the lady, all her reports will be checked for, and then the opinion will be provided in Form D with regard to the termination of pregnancy, or whether you want to reject the request for termination. But the board has to give its opinion within 3 days of receiving the request for the MTP. They cannot go beyond that. And once the opinion is given, the next 2 days, the termination should be done. And the termination procedure should be carried out with all safety precautions, appropriate counseling within 5 days of the receipt for the request. So within a week, the termination should be done or rejected. So this is the amendments, and thank you so much for the participation.
Thank you so much, Dr. Sharmila. And Dr. Ananda Khanna is here. A very warm welcome to you. As so very excellently and clearly, you have mentioned each and every aspect that from what has happened in 2021, that makes the things very clear and more distinct. The issue is that the training of the doctors to realize and also to rule out her health for safety of abortion, number one. Number two, ruling out ectopic pregnancy. That is becoming a very big point, and especially those who are having within 9 weeks, not by medical doctor, those who are not getting even PSPV examination done, they are not aware of even ectopic pregnancy. So that is a question to me. That then the most important point in my mind is about Ayush, homeopath, and our MBBS persons, that what is the government education regarding this, because are they so much legalized in a way to taking care of the safe and safest abortion? So this makes me very much in dilemma that where are we? So this answer I would like to listen from you.
Madam, the government is quite gray in certain zones, I would say. They have to be very stringent with the pharmacy not to distribute these tablets without the opinion of a medical practitioner. But we know it happens over the counter, and we know that other providers, the Ayush providers, also do it. But I think we have to make it very clear from the as an organization that this should not be done, because, as you said, we see enough of ectopic pregnancies rupturing, being misdiagnosed, diagnosed late, and the mother losing a life also. So that gray area has not been addressed by the government. And I would say even for copper-T insertions, a PSPV should be done before you do, but nurses just blindly put copper-T, and we see the ramifications of that also. So as an organization, we have to put forward to the government that a proper checkup, at least a basic checkup, should be done before you provide a drug for an abortion service. And that's why the training is very important. And even for up to nine weeks, I would say that they have to be properly trained by the people where they're working, because they take it quite lightly, and you will escape most of the times. And when you get caught in a problem, it's going to be very, very severe. And we have to tell that. And I kept on insisting on the 20 to 24 weeks, madam, because many gynecologists or service providers are assuming that they can do abortions for late pregnancies without any problem, because they've increased the age up to 24 weeks. But that 7 criteria, one of that has to be met before you do an abortion between 20 to 24 weeks, because gynecologists in our part of the country have got caught because they did abortions for women who came late. And you should have obtained an opinion from the medical board before you go ahead, because that 7 criteria, most of them don't meet. That rape, tragedy, widow, all that. Most of them are like a young girl about 20, and they want an abortion between 20 to 24 weeks of pregnancy. And we think it's okay, but remember that amendment is only for that 7 criteria. Up to 20 weeks, you're safe now. A single RMP who has done a diploma degree can do it safely, but 20 to 24, that criteria has to be met. Otherwise, many have got caught because they did for a little older gestation, like without the opinion of the medical group.
Thank you so much, Dr. Sharmila, making all the points so clear. And I will request Foxy, Dr. Shanta, Dr. Pai, and future also, that they should especially take care that registered medical practitioner should be actual registered practitioner, not that anyone can do it. And especially our medical colleagues, like medicine person, surgeon persons, if they are giving like 9 weeks below, acha ye tum dawa kha lo, and that becomes a big issue. Even the counters, patient, they go there and they purchase. Acha mujhe empty pill kit pakda do, and we are getting the worst cases out of those. So this was just a point of this. Otherwise, you make it so crystal clear. I really love your talk very much. Thank you so much.
Thank you, ma'am. Thank you so much for the kindness. Thank you.
Yes, proceed further, doctor. Any comment from Dr. Sudha Singh has
thank
also
you.
joined.
No, ma'am, I cannot see her on the screen. She has not joined yet. And ma'am, thank you so much for your valuable inputs. And may I request Dr. Sangeeta Roy, will you like to
Yeah.
add something?
Yeah, we are facing problems with the pharmacy only. Actually, on regular basis, they just on the outset only, without any prescription, without any knowledge also, they are prescribing, they are giving the drugs, MTP kit, and every alternative we get these issues. This is the main problem for us, that we are getting very patients in very bad conditions in the midnight also, when the blood level, hemoglobin level becomes 2 to 3 hemoglobin level, and then we have to manage that case. Otherwise, on the way only she can die. This is the main issue with us. We are following the MTP Act, but what to do with the pharmacy?
Madam, that's why I think we have to provide solid data. Like how many cases you get in a year, probably you should provide the data saying that they came without prescription. And suppose as a society you put up that data, we can ask every zone to do that. And when you get a solid data and present to the government, they will need to do something. Otherwise, without a backup, you go and say like, I see patients, they are not bothered at all, because they say instead of having an unsafe abortion by a provider, this tablet is much safer. That's what the equation they bring into the picture. But we know the reality. We know the reality that it's not so. It causes so much of complications when they take it over the counter. So we have to insist, and the way out is by providing data. So suppose like Dr. Shalini, she can ask her society members to bring out like how many patients they saw that particular month, and every month data you collect and present at the end of the year. That somebody will take notice of that. When there's a group, a collective, a society which brings out data, the government listens much better than our talking ourselves between ourselves in meetings, because we know the reality. We all of us face that in our OP, but somebody has to tell the government, because otherwise nobody is going to stop that pharmacist from giving the drug to the next girl also, because for them it's only income.
And recently I faced a case that one patient, mentally handicapped patient, of adolescent age group, came with parents with 32 weeks pregnancy. And I asked them to they were just requesting to abort. But in this case, I asked them.
The definition is not abort. At 32 weeks, you will say for preterm delivery. Many cases has come to me like this also. But I have counseled that just wait for 2 more weeks and give the dexamethasone and continue the pregnancy. By that, you can search an area where the baby can be adopted or searched, because that is a social problem. So I have done many cases. I have done many cases from very beginning till now also, that they should not be prematurely terminated very much, but they can go at least 35, 36 weeks, and you give them also dexamethasone, because that is their social problem. And there are so many NGOs, they are running, and we can inform them, look, here is a case like this, और उनको आप 1 महीने के लिए कहीं होटल में या कहीं रखवा दीजिए कि ये घूमने गई है, घर में बता देते हैं. मैंने बहुत केसेस किए हैं, और वो भी प्रेगनेंसी फ्रॉम द फादर. Can you imagine that I have done from so many cases of pregnancy from the father? So we have to conceal the data, don't tell it publicity, but we can save a life. And they have delivered on vaginally, normally, and then they were adopted by so many persons. They all, even I know about the baby, they are doing very well. Few of them are in America as engineers. So it is a thing, only your thought process.
Madam, it came in the newspaper today in the Bombay High Court. There was a girl who was like raped by a relative, and the pregnancy was diagnosed at 30 to 32 weeks. They said 5 months. It was 32 weeks. The medical board refused for the termination of the pregnancy. And as Anuradha Madam said, they asked them to continue the pregnancy, and the girl is under the care of JJ Hospital, Bombay. And when I was studying in JJ Hospital, Bombay, we had a ward where we had unmarried girls with late pregnancies diagnosed, and we used to keep them in the ward till delivery. And then the child was given for adoption from the hospital only. And these girls were sent with proper counseling so that they'll not have any problems later in their life, psychologically or physically. And Maharashtra has got that policy. Any unmarried girl who wants to deliver will be given free care in the government hospital.
True.
So thank you so much.
Also, is this in this state also, UP? Is there any facility for these unmarried girls?
Not
Yes,
in-
Mother Teresa home is taking care of such girls in Varanasi also.
Can I say something?
Yeah, Mother
UP
Teresa home is there, which takes care of such girls.
UP government is not doing it. UP government is not doing it, but we have NGOs.
Yeah.
Can
Is
I
it
just add the
still
line?
doing?
There is one Mother Teresa home in Shivala in
Yeah,
Varanasi, which
I
take
know
care
this.
of these unmarried girls. Yeah,
Okay.
they take care of that and they take responsibility of their full delivery.
That's
Yeah.
okay. We got it. It's very nice information.
But Anuradha madam, earlier we were doing by ourselves, but now you have to get a medical board's opinion and then admit the
Yes,
patient. You
that is
can't
true.
you can't send to the NGO
Yes.
directly without the medical
Yeah,
board's opinion.
no, we haven't done NGOs. That is the counseling among the doctor and her parents. And they continued. No NGO, no one in between. And then adoption was through legal processes.
Okay. Now, shall we proceed further to our second session? Hello?
Yes, Dr. Shalini, please
Yeah,
proceed.
shall we proceed further to our second session now?
Yes, please.
Yeah, our
please do.
second speaker is Dr. Mudita Jain Teleresa, and she will be speaking on safe abortion. And for the chairpersons for this session are Dr. Usha Yadav, Dr. Ritu Khanna, Dr. Anju Jain, Dr. Ishita Avasti, and Dr. Sangeeta Rai. Now, may I request Shriman to please share the CV of Dr. Mudita? Hello, Mr. Shriman. Please share the CV of Dr. Mudita on the screen. And now I'd like to request our very senior gynecologist, Dr. Usha Yadav, to please introduce Dr. Mudita.
Thank you, Dr. Shalini. It's my pleasure to invite Dr. Mudita. Dr. Mudita is professor in obstetrics and gynecology, and at present she is secretary of Bhopal Obs and Gynae Society. She is past joint secretary of Bhopal Menopausal Society as well. She has been faculty for 4th PG update program in 2019. She is life member of WALS, IMS, BOGS, and IMA. She has got fellowship in minimal access surgery. She has undergone FOXY recognized ultrasound training as well as recognized infertility training. She is also master in reconstructive and cosmetic gynecology, reconstructive surgery and cosmetic gynecology. And she has got several publications to her name, and she has been invited faculty in so many CMEs and conferences. Welcome, Dr. Mudita Jain. Please go ahead with your talk.
Thank you so much, madam, for such kind words. I hope my screen is visible now. My screen is visible. Hello.
No, not yet seen. Your slides are not seen.
Can meeting people can help me? My slides not able to share. I'm not able to share my slides.
Shalini, see who is
Hello?
controlling centrally?
Hello, Mr. Shriman. Hello.
Yes, madam. Yes, ma'am.
Please, Dr. Mudita is not able to share her slides. So can you help?
Madam is having access, madam. Can she re-log in the meeting?
Okay. Please coordinate with her.
Hello. see in my laptop it's coming, but it's not coming over there in your slide.
Now we can see, Dr. Mudita, we can see your slide. We can see your screen.
But make it full screen, madam.
Okay, I'm doing it.
Slideshow.
Okay. No, ma'am, now it's visible. Shall I start?
Yes,
Very
yes,
good.
yes. Yeah. Please continue.
So module 2, it's about safe abortion updates. So what we are going to see, the overview regarding this. So we have to see the existing guidelines, which madam has already told us about pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. So these are the WHO global guidelines on safe abortions. So these are being published by WHO. So these are the WHO national publications of safe abortion from 2012 onwards to 2019. So what are the changes and what are the handbooks printed by WHO? This is a roadmap to WHO safe abortion guidelines. So as we know, this was the historic change in 25th March 2021, which madam has already told us about the amendment on Medical Termination Act. So all the guidelines have three key areas in management of abortion safety: pre-abortion care, abortion care methods, aftercare and follow-up, including post-abortion contraception and counseling. So what we need for the decision making is medical history, the physical examination, if necessary and available laboratory and other investigations, and discussing about the options regarding contraception. So if the woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate for her based on the duration of her pregnancy and her medical conditions. So what are the pre-abortion assessment and counseling? So pre-abortion assessment for women seeking abortion is detailed history taking, general physical and pelvic examination, laboratory and other investigations, decision-making information on abortion procedures, and counseling. So gestation is determined by LMP or physical examination. What we had started learning from our first year of PG life is how to determine the uterine size by doing vaginal examination. So as we all know that uterus size increases approximately around 2 centimeter per week. So at around 4 weeks, we just get a bulky uterus. Around 12 weeks, we get the uterine rise out of the pelvis. Around 15 to 16 weeks of gestation, uterus just reaches the midpoint between the symphysis and the umbilicus. Around 20 weeks, we know it just reaches the lower border of the umbilicus. So the limiting factors for determining the size factor by doing physical examination is uterine malformation, fibroids, multiple or marked uterine retroversion, obesity, or molar pregnancies. So we have to think about this, and then we have to apply clinically that what would be the approximately size of the uterus and what would be around the gestational age. So pre-abortion investigation. Routine lab tests not a prerequisite for abortion services. Tests that may be performed as per individual risk factors on findings of physical examination. Pregnancy test is to be done if pregnancy is unconfirmed. Hemoglobin or hematocrit for suspected anemia. RH testing is to be done when RH immunoglobulin is available for RH negative women. HIV testing or counseling. STD screening should be performed before doing pelvic examination. Other laboratory tests should be done as per the history, medical history. Ultrasound is not necessary unless to diagnose of pregnancy not certain or suspecting ectopic or missed abortion. So the counseling part. So what we need to ask? We need to ask about the thoughts about terminating the pregnancy and the reason for termination. What we have to inform is early abortion is definitely safe. Importance of a trained provider performing the procedure for safety, available methods of abortion, risk and warning signs associated with the abortion methods. Without contraception, she can get pregnant as soon as 14 days after an abortion. Resumption of normal activities, including sexual intercourse and any other follow-up is required. What is the documentation we need to do? We need to do informed written consent, decision to accept post-abortion contraceptive. Even if she is not willing for contraception, she will be provided with abortion services. So what are the clinical management of abortion? So abortion less than 12 weeks, the global recommendations are combination of mifepristone and misoprostol. We can use only misoprostol if mifepristone is not available, and we can do vacuum aspiration. If for more than 12 weeks, again the combination of mifi and misoprostol only, we can use DNA. But as we all know, we don't do sharp curettage in pregnant uterus, so sharp curettage is not recommended. So abortion up to 9 weeks only, we all know that mifepristone 200 milligram orally we have to give. We have to wait for 24 to 48 hours, and then misoprostol can be given sublingually, buccal or vaginal route around 800 micrograms. So the clinical management of abortion. For first trimester abortion, we can use medical method abortions or surgical methods like manual vacuum or electrical vacuum aspirations. So regarding tablet mifepristone and tablet misoprostol. Mifepristone, as we know, is anti-progesterone. It inhibits the action of progesterone. It interferes with continuation of pregnancy. Initial oral dose of mifepristone followed by misoprostol, which is the prostaglandin E1 analog. It helps in cervical softening as well as uterine contraction and helps in exclusion of products of conception. So what are the advantages of so for on day 1 of if patient is RH negative, then we need to give anti-D microgram. On day 3 mifepristone administration, to 7 weeks, we need to give 400 microgram misoprostol, 2 tablets each sublingually, buccal, vaginal, oral, or around 7 to 9 weeks, 800 microgram. Though we use 800 micrograms only, we never use 400. I don't know if other people's review regarding this. We will discuss later on. In addition to this, we need to give analgesics, antiemetics, and offer contraception. So, and we need to ask them to have follow-up after 15 days to confirm and ensure completion of procedure of contraception if not already done so. So the characteristics of different which we identify in first trimester. Some says okay, we can give orally, some says okay, sublingually, some says vaginally. So for instructions for oral, please need to follow, and we recommend it up to 7 weeks for trimester. For the most common side effects include diarrhea, nausea, fever, and chills. For buccal, we are placing pills between the gums and cheeks. You can see in the picture of buccal mucosa. We keep them between the buccal mucosa, between the between the chin and the gums, and it should be swallowed after 30 minutes. The complications associated with these are more fever and chills as compared to the vaginal route. In sublingual route, pills are placed under the tongue and again swallowed after 30 minutes. It leads to increased fever, chills, diarrhea, vomiting compared to vaginal route. Fastest onset of action, highest plasma concentration levels. Vaginally, pills are placed in vaginal cornices, deepest portion of the vagina, and the woman is instructed to lie down for 30 minutes. Pill fragments may be visible. The side effects are lowest on vaginal routes. So these are the buccal and sublingual routes for misoprostol administrations. So what is the WHO drug regimen? Dose schedule for medical abortion. So recommendations for induced abortion less than 12 weeks. Mifepristone 200 milligrams per oral, followed by misoprostol by any route 800 micrograms. And alternatively, if you are not having mifepristone, so we can give misoprostol 800 micrograms by any route. Vaginal bleeding for 2 weeks is normal after medical abortion. Such bleeding can last up to 45 days in rare cases. So what is the provision of medical management abortion service? Services should be available at the primary care level with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortions. We need to have counseling and testing of STDs. We need to give abuse support services, psychological or social services, or other specialist health or medical services. We need to provide access for anemia. We need to have give them pain medications, as well as we need to have support to be given. So what are the follow-up cares? Routine follow-up is not necessary following an uncomplicated medical abortion using MIFI and MISO. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraception, counseling, emotional support, or address to medical complications. Only about misoprostol alone to assess success of abortion. The follow-up assess women's recovery and ask for evidence of symptoms of ongoing pregnancy, medical records and medical documents. Ask about any symptoms experienced during the procedure. For focused physical examination for complaints. Assess women's fertility goals and need for contraceptive services not provided earlier. So the summary is, first visit day one, what we need to do is physical and pelvic examination, confirm the eligibility criteria up to 49 weeks, 7 days or more than that. Then give tablet mifepristone 200 milligram orally. If RH negative, then need to have anti-D offered. So what do we need to tell the patient? Return for misoprostol administration after 2 days. Contact address and phone number of the facility center where she can go in cases of emergency. Record her experience of any side effect on the MMA card. 3% women may expect completely with mifepristone alone, but misoprostol schedule should be completed. We need to explain this to the patient that whatever happens, if bleeding started also after first dose, we need to complete all the 5 give misoprostol 400 micrograms by annually, observe for 4 hours, analgesic required should be given, and the contraceptive options condom hormonal method should be given. Tell the woman that mean period of bleeding is around 8 to 13 days. Possible side effects will be nausea, vomiting, diarrhea, headache, fever, dizziness. Report in cases of excessive bleeding, pain, abdomen, fever. Report if there is no bleeding 24 hours after misoprostol, consider giving additional doses of misoprostol. 75% women abort within 4 to 6 hours after misoprostol administration. Now for the third visit, that is on day 15, the follow-up visit, we need to have pelvic examination to ensure the completion of abortion. We need to tell them about the contraceptive options. We can provide them the basket of contraception. They can choose any according to their requirement. First, we need to tell the woman about the immediate return to fertility. Report back if there are no pills within 6 weeks of completion of abortion procedure. USG is only done if examination does not confirm the completion of procedure. So regarding the side effects and complications, pain we should be respectful for the pain limitations of the patient. We should not be judgmental. We should have non-judgmental communication with them. We need to give them verbal support. We need to give them adequate counseling. We need to support the person. We can give them ibuprofen 400 milligram. If pain is persistent with failure to respond to these drugs for several hours, we need to warrant evaluation for other causes such as ectopic pregnancy, infection, or incomplete pregnancy. Nausea and vomiting, they are self-limiting. We have to reassure them. Diarrhea. Diarrhea against self-limiting, we need to reassure. Infection. Confirmed by physical examination and starts antibiotics. So action for failure of incomplete results of MMA. Failure of MMA of the vacuum aspiration or repeat MMA. Incomplete results of MMA, that is, we observe them unless there is heavy bleeding. If heavy bleeding is resolved and uterus is normal, so then abortion is complete. But if heavy bleeding continues, we need to offer them surgical method of evacuations. We can also repeat one dose of misoprostol in case bleeding is if medical abortion is incomplete. So the excessive bleeding per vagina. Women present with excessive bleeding per vagina, bleeding that is more than her menstrual cycle, soaking more than 2 pads in 1 hour for 2 consecutive hours. Bleeding decreases over time, yes, routine care is to be taken, keep a watch on her vitals and bleeding per vagina, then they can go home. If bleeding doesn't decrease over time, then we need to watch vital signs. For vaginal examination is to be done. Product of conception is in the cervical canal, digital evacuation is to be done. If women is stable and bleeding is reduced, then observe and monitor vital signs and bleeding period for 1 more hour. But if bleeding continues, it doesn't get stabilized, then we have to do ultrasound. If minimal then wait and watch. If product of conception and decidual feeds are there, women is stable, then we can give misoprostol 600 or 400 micrograms. 600 orally and 400 micrograms sublingual. If women is not stable, her hemoglobin is decreasing, then we need to do vacuum aspiration. And if pregnancy is continued, then we have to do vacuum aspiration. Recording and reporting for MMA. Since MMA comes under the purview of the MPP Act, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill the following form. We now see the all new forms. Form C is there, which is the consent form. Form 1 is there, that is RMP opinion, registered medical practitioner opinion. Form 2, which we have to do monthly reporting form, which we need to have to send to the district authorities. Form 3 is the admission register for case records. Methods of first trimester abortion, that is surgical methods of abortion, either manual vacuum aspiration or electrical vacuum aspiration. Surgical abortion methods in first trimester. Vacuum aspiration is the recommended technique of surgical abortion for pregnancies up to 12 weeks. The procedure should not be routinely completed by sharp irritation. So, as what is the vacuum aspiration method? We all know MTA series. We had to hand aspirator create the vacuum. Then aspirator is attached to the cannula for 4 to 12 mm in diameter. As we know, the diameter of the cannula corresponds to the gestation age of the patient. So we can easily use IPOS or easy grip cannula size corresponding with gestation weeks of gestation. That is 8 mm cannula for 8 weeks gestation, 10 mm for 10 weeks gestation. So electrical vacuum aspiration, that is an electrical pump is used to generate vacuum. We can accommodate cannula of manual vacuum aspiration with correct size tubing. Cervical priming is required, may be considered for women with a pregnancy of any gestation age to prepare the cervix and make it soft and easy to dilate. Recommended methods of cervical preparation after surgical abortion in first trimester, that is oral mifepristone 200 mg 24 to 48 hours in advance. Misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or vaginally 3 hours prior to the procedure. Laminaria, which were previously used intracervically 6 to 24 hours before the procedure. So, what are the pain management plan for vacuum aspiration procedure? It is the important component of quality abortion care. It reduces pain and anxiety and makes women comfortable. Two components of pain management is there, that is pharmacological and pharmacological. That is the mix of medications. So what do we mean by non-pharmacological pain? Psychological support, explaining each and every patient in advance that, okay, this will happen at this time, this can happen at this time, you need to be aware of these things. We have to perform the procedure gently and smoothly, encouraging the women to relax and breathe deeply. The sources of the pain management, as you all know, for anxiety, cervical dilation, we can give them local anesthesia or cervical block or analgesics. For uterine clamping, again, analgesic and is there. So these are the dose timing, duration of effects, and side effects. So the steps of MTA. So we need to have prepare the instrumentation for this. We need to prepare the women. We need to give them ensure pain control medications at the approximate time. We need to ask the women to empty her bladder. We need to perform cervical antiseptic preparations. We need to give paracervical trough. We need to dilate the cervix and then they insert the cannula. We have to withdraw the cannula 1 to 2 centimeters inside the uterine cavity. We need to release the vacuum, but cannula for 10 to 2. We need to rotate the cannula into a position with smooth and gentle movements. And then we need to release the vacuum button on the aspirator. Positioning of the product. Science said the uterus is empty, bed of pink foam without the tissue passing through the cannula. Gritty sensations over the surface of the uterus, cervix slipping over the cannula, uterus contracting around the cannula, intense uterine clamping. We need to inspect the tissues. If the complete tissue is there, what are the concurrent procedures? We need to proceed with contraception methods such as sterilization or IUCD insertion. Instrument processing. Instrument should be soaked in chlorine solution to assist disinfection, helps remove tissue and body fluid. So what are the post-procedure care? We need to monitor him for any complication, provide management as needed. Facility criteria for discharge. We ensure the women all necessary information and medication prior to the leaving facility. Document all outcomes of the treatment, including any adverse events in the facility residence can report for. After care, management of abortion complications, abortion or infection bleeding or of contraception sexual and reproductive health. Important for this needs of around remedy use. This is the new requirement that we use only to do. So in India, in summary, India has made historic progress in.
I think some network issue.
I think we have lost Dr. Mudita
Yeah.
somewhere. It was a very interesting talk going on.
Mudita, are you there?
Yeah, she's joined again.
Mudita, if you can't share, just read off
No,
the
ma'am, I'm
material.
there, but my screen is lost.
Okay, yeah,
So
we
just I
even
need to
can't
say
see your
that,
screen.
Yeah.
You can just
Ma'am, this is my last slide. I just read it out. Okay.
Yeah.
So we need to ensure the safety and quality, especially in the context of the amended law.
Yeah.
Along with safety, we also need to focus on respect to abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling. Thank you so much. We need to have registration, pre-test, and post-test along with the feedback form to get the certificate for this CMA.
Okay. Thank you so much, Doctor. Thank you, Dr. Mudita. It was really a nice talk. Now, I will like to request Dr. Ritu Khanna to share her expert views on this topic.
Thank you so much, Mudita. That was very, very lucid, very informative. And you know what, you really brought us to the protocols, pre-investigations and the abortion care and everything. And we really need to take care. So many 39,000, I think, deaths globally occurring due to unsafe abortion. And the only thing was that we need to take care, I think, of the quality, and they have to have an excess. And the access is very important. A lot of health workers we need, you know, and accurate information, like you told us. I think we need to put it into our clinics, all the modules that we have, so that even we don't skip over it. But and the forms you had mentioned, yes, we need to fill, but we still be scared about, you know, the over-the-counter drugs that they are taking. So we do not have any data, and that's a good suggestion by Chamila, that we can just keep a data how many of them we got as our own patients when we gave them, and how many were the over-the-counter pills and all. So that's where I think the data would be lacking. And the important thing is the one which is removing all the medically unnecessary policy barriers which have been done, all the legal issues, the procedural, practical and all. So it's made it more accessible, and it was a stigma, I think, for them. So, and it's a right of an individual to make, I think, an autonomous decision. So that fantastic presentation of the SIB abortion was, I think, a bit to prevent the health of women and girls. So thank you so much once again for all that decorum, and we really need to follow that.
So nice, Dr. Ritu. It was nice sharing your views. Now, may I request Dr. Anju Jain, who is another chairperson of this session, to share her views on this topic.
Thank you, madam. And it was indeed a pleasure listening to Dr. Mudita giving us the right overviews, and so that we should be aware well before we can explain the patient who have already taken over-the-counter drugs some way or the other. They might hide it also, and actually our main motto should be that this abortion practice is safe, and they should approach to a gynecologist or per se any doctor. Just take a view or take a advice before taking any medication herself, or by a chemist, or by a husband buying a drug and giving to her and she's taking it, and we all facing the aftermath of that, whether she's bleeding heavily and she's already anemic, she's bleeding, then she's coming to our chamber heavily bleeding, then landing up in an emergency evacuation. We need to avoid all those things. And perfectly, first of all, we have to give information regarding contraceptives, so we avoid them taking all these things, if they take proper contraception at the time of delivery, if we are explaining each and every woman the rights they have, the knowledge about various contraceptive measures, then we can avoid all these unsafe abortion deaths. This is our duty, I believe.
Yes, Anju, we agree with you. Yeah.
Dr. Shalini, may I share one view of
Yes,
mine?
ma'am. Yes, ma'am.
Okay, in clinical practice of mine, though I have not gone for publication for it, that I have seen the first one dose, one pack that you give it, and then next day you give 4 tablets instead. 50% failure. 50% failure is there. And then I have changed, modified my view, my patient, that if he has to purchase a kit of 300 or nearly whatever, 400, whatever it is costing, why not to purchase 2 or 3? Increasing the dose of RU 486. Though it is said that 25 milligram is sufficient, but I have seen my practice that once I had given her 3 packets and I say, take all these 3 mifepristone together, then wait for 1 day complete. Then second day means day 1 of taking, 1 week gap, then from day 2, not 4 tablet at a state, or you may give 4 tablet also, but repeat rest of the tablets given to her, that 2 tablets sublingually 4 hourly. I'm telling you, none of my case has a failure. But I have seen 50% failure with one kit. So this is my clinical suggestion. Those who can afford it, or those who can get as such from the government, because they all get reimbursement also, or some scheme is preventing them, then treat the patient full-heartedly, not half-heartedly. This is my clinical suggestion.
Yes, ma'am. Thank you so much, ma'am, for your inputs. And now shall we proceed to our third session? Our third speaker is Dr. Apurva Kumar Datta. Dr. Apurva, you have joined?
Yes, ma'am.
Yeah.
Hello, everyone.
Thank you so much. Thank you so much for joining, and we welcome you here. And for your session, we have esteemed chairpersons, Dr. Sulekha Pandey, ma'am, a very senior gynecologist and a retired head of the department from IMS BHU. She is also mentor of Varanasi Obstetrics and Gynae Society. Then Dr. Neelam, ma'am, I think she has not joined. Dr. Madhulika Singh, she is also a very senior gynecologist and a private practitioner from Varanasi city. Dr. Smita Tandon, she is also a very senior gynecologist and a private practitioner.
Good evening, everyone.
Yeah. And Dr. Uma Pandey, a very dynamic gynecologist, and at present she is head of the department of IMS BHU. We welcome you all, chairpersons, and our guest speaker, Dr. Apurva also. So now may I request Dr. Madhulika Singh to please introduce our guest speaker. And Mr. Shriman, please share his CV. Dr. Madhulika Singh. Dr. Madhulika, can you hear me? Please unmute yourself. Dr. Madhulika, you have not unmuted yourself. Yes, yes.
Okay.
Now,
Okay.
please.
Yes. Good evening, everyone. It is my privilege to welcome Dr. Apurva for this program. And I cannot see CV. Shalini?
Ma'am, it's not required. Thank you so much. It's absolutely.
And
I just
he's
wanted to say,
MBBS, MD, gold medalist, FMAS, FIOG, RCOG, associate consultant of Sri Durga Clinic and Fertility, Dhanbad. Red CV, it is not seen, so I cannot say. Now I welcome you for this important topic.
Thank you so much for your kind words and generous introduction. At the outset, I would like to thanks to respected Ritu Khanna ma'am and to the Varanasi Yoga Society to invite me, Shalini ma'am, the Lavina ma'am, all the seniors are there. Thank you so much for inviting me and organize this a wonderful, teaching that's MTP, which is actually, I think it's a a art which is changing rapidly, and we should update about the new changes what we are going. Can I have, please unshare your screen, Meti? Yeah. Before I go into my topic, I just want to just 1 minute. It is visible?
Yes, it is visible.
Okay. Now, before I am going to my topic, that is what is the safe abortion value, evidence of the rights respect as a saver, what's our duties. My dear friends, before we going into detail, I just wanted to tell you few things of the past. When the Santi Lal Saha Commission was made by Government of India, we are very proud that Foxy leadership was invited as one of the member. And we Indian are among the first country, we India are the first country who actually adopted this safe abortion, laws. So I am really proud of you, of all of us, and we Foxian as, because we are always give our best for, well-being of the women of our country. So when I'm talking about about this module, about what is the savers, the aim of this module is defined the respectful abortion care. What is the WHO standard? To highlight how norms and stigma affect the services. And last one, to provide WHO saver rescue for the respectful abortion care. Now, when this momentum has created, now I have already stated about the Santi Lal Saha Commission in the as soon as in the year 1970, then come in era in 2000, when it was modified, and in 2021, when there is a drastic and lot of changes are made, then this respectful abortion topic is get the momentum. Why we get the momentum? Because the law has changed. Because the Foxy is the largest provider based for the abortion care. And since the online training is possible due to COVID, thankfully, the COVID has given us a lot of negative things, but online training and online things is one of the positive things of COVID. So respectful abortion care can reach to all the providers. And finally, the MMA uptake increases, the early abortion ensure no PCP-NDT confliction. The patient safety, respect, and quality matters more than ever, and we all have a role to play of it. Now, what is respectful abortion care? It is adapted from the respectful maternity care recommended by WHO. The respectful abortion care means that maintain the safety, dignity, confidentiality, ensure freedom from the harm and mistreatment, and enable informed choice and continuous support during and after all type of abortion. This is what the respectful abortion care means. What is respectful abortion care? In a simpler form, it means to treat with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. That is the number of pregnancies, miscarriage, and abortion. If you ever feel that something is not right, speak up. As a health profession, in our duty to listen and support, the communication is the key of giving this service, that is the respectful abortion care. What are the norm and the stigma? The norms are the category of disrespect and abuse. It is either in the form of physical abuse, like slapping, or intimidating physically, verbal abuse, or the sexual abuse, stigma and discrimination, discrimination on the basis of race, discrimination on the basis of socioeconomic status, failure to meet the professional standard of the care, poor rapport between the women and the provider, and the health system condition and constraints. What is the right of every woman? The freedom from all the harms and ill treatment. the right to information, the protection under the law, either in the form of MTP law or POCSO law, informed consent and refusal, respect for the choice and the preference, dignity and quality of the care, right to timely healthcare and to the highest attainable level of the health, liberty, autonomy, self-determination, and the freedom from coercions. What is the domain of the respectful abortion care? There are 12 domains of the respectful abortion care. The first, being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choice. What is that means? That means if a person is coming, a woman is coming and she wants to have an abortion, we should not say, hey, you are going for abortion. Why not you continue? We should respect the choice of a woman, engaging with the effective communication, that is the soft skill, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of the physical environment and resources, providing equitable abortion care, availability of the competent and motivated providers, provision of contraceptive advices and commodities security, continuity of the care and the counseling. These are the four, domain of respectful abortion care. Now it's the time to strengthening this, with the dignity and of this implication of the respectful abortion care. Now, what is the important change for the provider opinion? Every patient is an opportunity for the respect, and as a provider, onus is on us to educate and also to reduce the sex selection abortion. Ma'am, Charmila ma'am has already stated that about the one RFP, about the new law, I'm not going to detail, but one provider can be given up to 20 weeks of gestation. Between 20 to 24, the 2 RMP is required. And if it is beyond 24, then medical board is required. The expand eligibility, especially the young people, survivor, unmarried, everyone need unbiased care, and we need to overcome our own bias. So up to 20 week of gestation, I have already, all women can be provided with the 20 to 24 week of gestation. In case of special categories, special categories like rape, or if it is less than 18 years, we have to inform, come under the POCSO Act. And if there is a birth defect, there is no limitation of gestation, but a board is needed. So by doing that, our government has given women their whole right. Prioritizing the confidently and safety, respect, beget respect. So the provider, we need to be mindful of the socio-cultural aspects. Name and other particular of any women seeking the abortion is to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of the contraceptive has been extended to the women and her partner. So respect, equality and dignity of all the kind is a must in giving, when you are giving the respectful abortion care to your patients. Now, guide to avoiding is stigmatizing languages. What is the WHO is saying? From 1970, from unsafe abortion, in 2000, it's come to the safe abortion, and in 2020, now it is a respectful abortion. So what are the questions which we have in our mind? According to WHO, the restricting access reduces the number of unsafe abortion. The answer is false. No. If when you are restricting the, anything, the unsafe abortion is actually increases and it's not reduces, which is beautifully explained by Charmila ma'am. So when it is known as safe, when it is by appropriate method and by a trained person, then abortion is considered as safe. When it is less safe, when one of the two criteria is met, another is not met. When the both criteria was not met, it is considered as a unsafe. Now, next question. When a 30-year-old woman, recently widowed, want to get an abortion at 22 weeks, as a provider, it is your responsibility to tell her to continue her pregnancy. The answer is no. because it is her decision and we have to respect their decision. And I have already explained 1 RMP, 20 weeks, 20 to 24 weeks, 2 RMP. And before 24 weeks, in case of birth defect, there is a no age limit, but medical board is required. So, my dear friends, in India, abortion is legal. Let us make it safe and respectful. Amart Bharat, Sampoorn Bharat. Thank you so much. Over to the chairpersons.
Thank you so much, Dr. Purva. It was really a wonderful talk. Now I would like to request Dr. Sulekha Pandey ma'am to give her expert comments.
Thank you very much, Dr. Apurva. You have very nicely covered the entire topic and in very short. Okay. So you have already explained the respectful abortion care. You know, about 22 million unsafe abortion takes place every year and resulting in death of 47,000 women, and about 5 million women, they suffered the disability caused by even now. So what we require is safe, legal, induced, and of course for care of abortion. Now, WHO had developed from time to time policies. It has modified from time to time. FOXI has intervened from time to time and developed its own policy. So what at the end, what we require is respectful abortion service. Now we have to protect our women and fulfill the human rights of the women to provide good and safe abortion services. Of course, at the same time, we have to give contraceptive information to all the women. And we have to treat every woman the same, whether she is poor, she is an adolescent girl with pregnancy seeking for advice, whether it is a rape survivor, or if it is an unmarried woman, or if she is HIV positive and or with a full-blown AIDS. We have to maintain the confidentiality. We have to provide equal service to all. For this, we have to train our service providers, and every woman should be treated with dignity, and the quality care must be there. I often go to UK and I find even a small person, small women is treated in the same way as you can say a very high profile woman. Both have the same approach. They have the same approach. They can go to the same NHS and same service will be provided. And everywhere, even I remember when I had gone there to attend the surgery of my daughter, I was turned out and said the entire thing will be told to the patient only. So they maintain the confidentiality. They do not even tell the husband or the mother or the father. Here what happens, if a girl steps in with illegal pregnancy, the first thing we say, call your partner, call your mother, and then you get a very, she is already frightened and she is never treated with same dignity. So WHO has changed the whole view. Every girl, every adolescent girl, every woman, every lady who seeks for abortion should be treated with dignity. Further, we need a good quality care, and we have to individualize the case. And as we were teaching about 30, 40 years, cafeteria approach, when the girl or the woman comes to you, you have to listen carefully what she needs. And then you have to provide, if she's all the methods that is available to her, leave it to her to choose. If she cannot choose, then you allow her or help her to choose the method. Then give a good quality care so that to avoid many of the complications. Then for future advice regarding the family planning advice should be given to her. And she should be told all the hazards of abortions. Even with the safe hand, there can be complications. Provide them and then listen to them as soon as they come. Do not delay. Do not delay. If she wants termination now, not that you just ask her that you come after 1 month or come with this report and that report and all that. So what I think every woman, when they seek for abortion, should be treated with full dignity and quality services should be given. For that, we need the training to the providers.
Thank you so much, ma'am. Thank you. Thank you so much, ma'am, for your valuable inputs. Now, may I request Dr. Uma Pandey to share her views on this topic? And be very brief, Dr. Uma. Dr. Uma Pandey.
Ma'am, I think she is not
Some
there.
network
She
issues with her.
put
Shall
it.
some
Yeah,
network
yeah.
issues with her?
Okay.
Okay, may I request our next chairperson, Dr. Smita Tandon, to share her views? Hello, Dr.
Yes.
Uma.
Doctor,
You've done.
okay.
Please share your views on this
Dr. Uma.
topic and be very brief, since we are running
Yes,
short of
ma'am.
time.
Sure, I'm brief usually.
Yeah.
I just wanted to, Apurva is my good friend. We have done a couple of lectures together on sexual and reproductive medicine, isn't it? Apurva, you might remember that.
Yeah, ma'am, of course.
I just
How
want,
can I forget?
yeah, I would just like to beg to differ a little bit. When I heard, I was traveling actually, so I just heard you were saying that the woman comes to OPD asking abortion, and you should respect that. I respect your view, and I would follow. But there are situations in which a woman might not ask something. So that is your role as a doctor. My role as a doctor is to give them informed decision. You inform them. Like I had a woman who the baby fetus has micrognathia, and they were dead adamant. No, I want termination. So I said decision is yours at the end of the day, but I would just give you the informed information, and you can decide. So that's informed decision making is there. So that's all I needed to wanted to just say actually.
Thank you so much, Dr. Uma. And now may I
Thank you so
request
much,
Dr.
ma'am.
Smita Tandon to please share your views?
Yes, everybody has already told what to say, but ultimately, Dr. Poov, you spoke very well. Your talk was very good. Thank you.
Thank you so much.
Apurva, this was a wonderful presentation. Thank you for being in Varanasi Society with us.
Thank you so much, ma'am. Ma'am, Varanasi is like कि भाई मैं अभी छलांग लगाऊंगा और पहुंच जाऊंगा
You'll
from
be there.
Dhanbad से.
I know.
So it's so close from our society, and it's really wonderful. Previously also we had
He
in
always
sexual
likes
medicine.
coming to Varanasi.
Yeah.
Thank you.
Thank you so much. And now we'll proceed to our next, our last topic. And the speaker of the last topic is Dr. Gurpreet Batra. And for this,
sorry to interrupt you. Madam, there were 3 videos we missed in the last PPT, madam, last slide. I'll play the videos, then we'll take the last topic.
Okay. Proceed further, please. Please proceed.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Health care provider is usually a more accurate term to use than abortion provider, as most of In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Thank you, Mr. Shriman. It was a very nice video from Foxy End. Now we'll proceed to our last session, which is very important, and that is family planning counseling pre and post abortion. The speaker of the session is Dr. Gurpreet Batra, and the chairpersons are our esteemed most senior gynecologist of Varanasi, Dr. L.K. Pandey, sir. Sir, we welcome you in today's webinar. Dr. Madhulika Mohan, Dr. Divya Agarwal, and Dr. Anu Agarwal. So now may I request Dr. Dr. Divya Agarwal to please introduce our guest speaker, Dr. Gurpreet Batra.
Good evening, everyone. It's my pleasure to welcome Dr. Gurpreet Batra. Dr. Gurpreet Batra is the consultant IVF specialist, Nova IVF Ludhiana. She is the member of the editorial board, ISOPAR Prayagraj Chapter and Society of Menstrual Disease and Hygiene Management. And she is the ex-registrar of Max Hospital, New Delhi, and Maulana Azad Medical College. She had taken training in hysteroscopy from Dr. Osama Shaki and training in ART from Rainbow Hospital, Agra, attended various seminars and webinars, and contributed chapter in menstrual hygiene manual by SMDHM. And she is also the executive member of Women's Wing AMA. I invite Dr. Gurpreet Batra for her talk.
Good evening, everybody. Am I audible and clear?
Yeah.
Okay. Good evening. Hello from Punjab, from the land of Golden Temple and the land of Fulkari. Hello, everybody in Varanasi. And I pay my regards with a lot of respect to Dr. Ritu Khanna Madam, Dr. Uma Pandey, Dr. Smita Tandon, Dr. Shalini Tandon, Dr. Lavina Ma'am, all my seniors and colleagues in the session today. My humble regards to Dr. L.K. Pandey sir and all my esteemed chairpersons. And request you to please start sharing the slides. Ma'am, can we have the slides, please?
I think you were supposed to share your own slides, Dr.
Ma'am, he's sharing them for me. I had talked to him.
Okay. Thank you.
Yeah.
Thank you. Yes, he's starting here.
Yeah. So today I will be talking about pre and post abortion family planning counseling. When we talk about respectful abortion care, at the opportunity of dealing with a woman and her abortion, we take this opportunity to counsel her regarding the family planning options that she can have. As in our previous talk, we have discussed that we do not do any moral judgment. We do not do any individual criticism to the lady who has come to us about why it happened or how it happened. But as a clinician, as a gynecologist, our role is to give them the safe option of an abortion. So at the same time, at that opportunity, we make an attempt to counsel her, to give her the options of family planning options, so that she does not have another unintended, unwanted, or a mistimed abortion. And as such, counseling is described as a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perception. So counseling itself is not a one-way communication. Next, please. It is the sharing of information where a medical practitioner will give in information and deliver the correct information considering the circumstances where the subject of the conversation is perceptive to understanding it. This is an integral part of comprehensive abortion services, and it is as important as the procedure of abortion itself. This is our doctors as a community an attempt that the woman does not have any more abortion. She is at least aware of the options and choices she has. A woman may actually need help in decision making. Sometimes she may know of the options like barrier methods and copperties and tablets, but she doesn't know what is good for her. So there is our role into giving her the basket of choices, weighing the pros and cons, and guiding her into making a choice. And wherever needed in such a situation, the spouse may also be called and counseled, because there are a lot of places where the woman says she has no control over her fertility. So those are the moments we can call the husbands or the partners and include them into the counseling session. This has three parts: help, ensure, and help. So we help the woman to decide about the termination of her pregnancy. We have talked about this in detail in the previous talk. We also help the woman to decide the method of termination. Again, we have discussed it. At the time, we ensure the delivery of complete information about the procedure. And after the procedure, we help the woman to adopt a contraceptive method. We cannot ensure it, but as a practitioner, we can counsel them and we can help them and guide them into taking up a method. So as a counselor, or taking that opportunity of counseling, our primary role is to ensure privacy and confidentiality. We do not need to talk to the mother-in-law, mother, parent, or other family members, but a spouse can be called in. We should be non-judgmental, but we should be sensitive to her situation. We must have already established a rapport by the time we are dealing with the procedure for her. But even at the time of counseling, it is important to maintain that rapport, be empathetic, understand that something was not intended or mistimed, and she should not be doing it again. We should use simple communicative language, either vernacular language or simple English without any technical terminology, and allow the woman to clarify her doubts. We need to be a good listener sometimes. We need to tell her, do you have to ask anything? We have to give her time to think about it, to ask us questions, and we need to very patiently answer her queries and doubts so that she is able to make a good, healthy choice for herself. If she has made up her mind for termination of the pregnancy, we need to assess her for the procedure. Next, please. And when we are counseling them about contraception, we need to, tell her that 90% of abortion-related mortality, morbidity can be prevented by ensuring contraception. When talking about contraception, we need to address the following issues: that is quick return of fertility, the time gap between two pregnancies when she can actually plan an intended pregnancy should be at least 6 months. We should take advantage of that time, because at that time she's in a vulnerable stage, she's undergoing an abortion. She's probably the most receptive to accept contraceptive advice. And also we should guide her about the health benefits and better future pregnancy outcomes on the use of contraception. So when to start as a counseling? Our counseling as a gynecologist starts on the first visit or the first consultation. And we should counsel about the return of fertility. It can vary from 10 days to 4 weeks, depending on the method of contraception used. We can help her to pick a choice. If she unable to decide, or she says, "Mujhe nahi pata hai, I don't know, I can't decide, doctor, you decide for me," then we should weigh the pros and cons. We should guide her and we should tell her that, look, I feel this is the best for you. If you agree with me, let's go ahead. And if you're not comfortable after a month or maybe 3 months, we can have a discussion again and we can change the method of contraception. Instead of telling her, okay, you can't decide, so don't decide, we should not call a quit on that. We should counsel her to make her accept any one method now and reevaluate the choice after some time. We should have method-specific counseling. Please go back. And we should also assess for her high-risk behavior. And in all this, when a woman clearly says, I do not want any contraceptive, she may have some bad experience, she may have some friends who have been guiding her, she may have some religious issues, we as a practitioner should not refuse her MTP. And after the MTP, again, we can call her up on a follow-up visit a week or 10 days later and have a second counseling session. So our job is to counsel, and to reinforce the benefits of contraception at this time. And as a general, the guiding rules are like when the contraceptive can be accepted is when the abortion process is complete, when we know that the process is complete, done in a safe method, there is no existing infection, there is no genital organ injury, and the chances of another second pregnancy have been ruled out. Like if a patient comes to us after 3 weeks of the abortion, then we have to ensure that she has not had unprotected sex in that duration of time, she has not been with her partner, and there is no risk of another pregnancy having occurred in that time before we start her on any contraceptive method. So for the post-procedure counseling, there is a critical role of a gynecologist in ensuring that the woman has understood the precautions and the care needed to her for her body in the post-abortion period. We need to give her the dietary advice. We need to give her the medical advice to watch for her bleeding. We need to ensure that when she gets sexually active, she follows some contraception. It is an opportunity to counsel for contraception in case it has not been previously accepted, and we need to reinforce the continuation of a previous method which she was doing. In case it's an abortion because of a contraceptive failure, we need to tell her that failure is a part of it, it's normal, and she still has to use contraception. She should not stop using it altogether. Next, please. So our job again is to reinforce, continue, reassure, and repeat. We ensure her privacy and confidentiality. We reassure her in case she has questions, queries, we solve them out for her. And we repeat all the information post-procedure. We alert her on the danger signs of any complication, and we reinforce the need for contraception. Next, please. So if the patient is already opted for a contraceptive, we need to reinforce it. We need to guide her about the immediate care of her intrauterine copper device, or we need to tell her on to how to continue her ongoing oral pills. And we need to maintain a continuity. We need to keep her on a follow-up, and we need to encourage and appreciate her usage of contraception. And in case she's undecided, she's confused, she's in pain, or she's disturbed about it emotionally, we need to be empathetic. We need to allay her anxiety. We need to convince her on the importance of immediate adoption of contraception versus a delay of contraception. We can also call for the spouse and the partner for a session of couple counseling. And we need to discourage the role of emergency contraceptive pills and encourage a continued method of contraception for such a lady who has come to us for an abortion. So a brief detail about the post-abortion contraceptive methods. I think it's just an overview of all the gynecologists, they know about it. So barrier methods, condoms can be used right after a first abortion or a second trimester abortion. They have no side effects, readily available, and they prevent again all infections. And it involves the male partner actively into taking responsibility for contraception. The acceptance of barrier methods in our country is 50-50. Some people don't like it, some people accept it readily, but we as doctors need to keep reinforcing it. Next, please. For an IUCD, it can be inserted immediately. PP-IUCD, postpartum IUCD insertion is an ongoing government program, or it can be inserted up to 12 days after confirmation of a complete abortion. With a medical method of abortion, it can be inserted around 15 days after the process of complete expulsion of the products of conception. After a second trimester abortion, it can be given only after up to 12 days of the procedure, ensuring that there are no contraindications in the uterus, no fibroids, no growth, no adenomyosis. It's a highly effective method. It's irreversible, ensures good contraception for up to 5 years. It can be, and it should be provided by trained doctors or qualified surgical staff at the time of abortions. And PP-IUCD program itself is a very big success being done by the WHO. Next, please. Combined oral contraceptive pills, patients who were already taking it will be guided into continuing it appropriately. It can be started immediately after the abortion or up to 7 days after a surgical abortion in the first trimester and second both. We can always add on the benefits to the patient about regulation of her menstrual cycles, about reducing the anemia, about the contraceptive and the other non-contraceptive benefits like, reducing the risk of endometrial and ovarian carcinomas, about reducing the size of fibroadenomas and fibroadenomatosis. But with the contraceptive pills, we need to be aware of the contraindications. They cannot and should not be given to women with a disease, deep vein thrombosis, with heart disease, with liver disease, women who've had some reactions to any of the components of the medicine. The benefits like no interference with sex need to be highlighted to the woman, and also COCs give women a complete control over her fertility. We can highlight such points to encourage them to adopt COCs as a method of continued ongoing contraception. Next, please. Long-term injectables like Depo-Provera injections, medroxyprogesterone acetate can be given immediately or up to 7 days after a first trimester and a second trimester abortion both. They are also highly effective, complete confidentiality and privacy is maintained, no interference with the sexual activity. They are highly effective for lactating women. They do not affect the quality and quantity of breast milk. Also, for this, a woman does not need to tell or ask her partner. A complete confidentiality can be maintained. The return to fertility is very good after the use of injectable contraception. So we need to weigh the choices with the needs of the patient concerned, and then we can give her correct advice on which would suit her. Next, please. Permanent methods. This, we can also take this time as an opportunity to encourage the adoption of permanent methods like female sterilization and vasectomy. If a lady has had a complete family and she's had a couple of unintended pregnancies, or she's had some difficult situations, at this opportunity, a woman is most receptive to advice for a permanent method. And if the woman does not agree, if you're having a couple to be counseled, the husband is also very receptive to the procedure of vasectomy, and we can highlight the advantages and disadvantages. Advantages would be they are effective immediately and they're highly effective. There are no long-term side effects. Also, they have a protective effect in the ovarian cancer. And we need to let them know that this is not going to be reversed. If a patient is accepting for these, I think it's very good for such a patient who has had more than 1 or 2 abortions and has already had her family complete. Next slide, please. Next, please. So this is a flow chart which just highlights on which day to which day can which method be started for a particular patient. Next, please. And as gynecologists, I am sure we all know about this and we don't need all this to be revised. But just to be sure, all of the methods actually can be done on the day of abortion or within the first week itself. So this just reinforces that when you are counseling the patient for the abortion and when you're doing the procedure, that is the time to establish a relationship, a rapport, a good communication with the patient, and if required, her spouse. And we should start the counseling and contraception right at the day of abortion or within the first week. This 1 week gives us the window of opportunity to not let the next abortion happen, to increase their acceptance of contraception. Next, please. So coming to the SRH services, sexual reproductive health services, using technology to improve upon this, that is a teleconsultation and other technology. Next, please. So in teleconsultation, we can, communicate a patient. If they're scared of talking to us directly, we can have a teleconsultation, we can have telecounseling, we can have teleguidance, telereferences. Next, please. This is an evolving use of technology in our medical practice. Next, please. So we have these websites like Hum Dono. Ask Tanu is a channel on Instagram and Facebook. YouTube has innumerable videos by us doctors, gynecologists, consultants, by psychologists, by counselors. We can have helplines. We have a lot of very nice patient education platforms made by the WHO, by the Ministry of Health and Family Welfare India, by the RCOG. And we should guide the patient to access these for any more information that they need about usage of contraception after an abortion has happened. Next, please. So now doing a SWOT analysis of usage of technology. SWOT is considering the strengths and the weaknesses of a technology that we are going to use and what opportunity it gives us to make it better. So in the COVID era, we figured that using technology, using these webinars, our teleconsultation facilities, using this digital technology to connect with each other, The doctors and the counselors can be approachable throughout the process. Complete confidentiality can be made out. Awareness and interaction can be done at a very personal level. And it gives us the opportunity to maintain the comfort. It cuts down the number of visits a patient has to come to a doctor to clear her doubts and queries. It is effectively saving the cost of doctor building up her infrastructure and saving the cost of the patient. But then it has a couple of weaknesses, like the intimacy of a face-to-face or a personal consultation. Like, in a webinar, we are just looking at each other and talking to the screen. But when we meet at a conference, there's so much of warmth, so much of love. Similarly, with the patient, there is a weakness of not having a face-to-face consultation. And also sometimes there can be a misdiagnosis. An ectopic pregnancy can be missed. An ischemic cervical pregnancy in the previous cesarean scar, a Cornwall pregnancy, the diagnosis can be missed, or there can be a delay in the correct diagnosis. So we just need to balance the use of technology and a real-time physical interaction to give the best option of abortion and contraception to the patient. But the technology, a teleconsultation, telemedia, Zoom calls, video calls, can be used for counseling purposes. And let's talk about how. Assessment, early diagnosis, consultation, early checking of the reports can be done on a digital media. The needs of contraception for the lady can be assessed. A video conference or a Zoom call or a Zoom meeting like this can be very comfortably conducted in the privacy of somebody's bedroom, in the privacy of, a husband and wife talking together to a doctor without having to come to a doctor's clinic, without having to reveal their whereabouts. And that probably will increase the acceptance of contraception among women. So I think, and WHO also thinks, and our Foxy also thinks, that a combination, a hybrid of services, where there's a one physical real-time consultation where the doctor and the patient, they establish a rapport, they bond, the doctor understands the needs of the patient and has to reach a correct diagnosis, can be followed up by up to 2 or 3 teleconsultation visits to give them a comprehensive abortion and follow-up family planning counseling services. So we need to realize the need of post-abortion family planning, bring the couple on board. After the abortion, it is important to involve the partner and the spouse and strive for 100% contraceptive coverage. We should capitalize on the basket and the applicability of the post-abortion period at the time the woman is most emotionally vulnerable, most accepting to the contraception. And technology, as far as possible, there is a scope for entry into medical services, but there are big concerns of malpractice, cost of service, accessibility in certain rural areas. Even for us, sometimes network issues and connectivity becomes a problem. So these are issues we need to concern, and as technology is evolving, I think we will do better in that. So for the people who are attending this conference, there was a registration and a pre-test and a post-test. Certificate is going to be awarded to all the participants on attending the training completely and submission of the test, post-test, and the feedback. And I take this opportunity to thank the esteemed Varanasi team for having me here and for their time and for the patient listening. Thank you, madam. Thank you, sir. And thank you, everybody.
Thank you so much, Dr. Gurpreet. It was really a wonderful, wonderful talk. Now I'd like to request our esteemed chairperson, Dr. L.K. Pandey, sir, to share his views. Dr. L.K. Pandey, sir.
Sir, unmute. Sir, mute.
Sir, please unmute yourself. Sir, please unmute yourself.
Can you hear?
Yes, sir. Now we can hear you.
Gurpreet, Sat Sri Akal. I recall with pleasure my visit to Amritsar when I got the opportunity to taste Amrit from the Sarovar. They have presented very nicely, in detail, everything.
Thank you, sir.
All the finer points. But unfortunately, our hospitals and clinics are not equipped. They are not keeping all the spectrum of contraceptive measures. So it remains 2 or 3 items and patients select one from them. So First thing is that we must ensure that all family planning clinics should have all the spectrum of 8 or 10 items. Then only lady can select the appropriate thing. And once again, thank you very much for nice presentation.
Thank you, sir. Thank you for your valuable words.
Thank you so much, sir. And now we've come to the end of this wonderful webinar today. And I would like to thank Foxy for organizing this very important webinar on respectful abortion care and providing us all the technical assistance in this webinar. And thanks to Mr. Shriman, who was taking care of all the technical details. I would like to thank all the speakers who really did a wonderful job today. And they really enlightened us in this very, very important and a burning topic for all the practicing gynecologists. And I would also like to thank all the chairpersons who chaired the session so wonderfully and patiently, and they shared their important views with us. And I would also like to thank all the participants. Thank you all so much. Thanks a lot. And have a nice Sunday evening today. Enjoy your evening. Thank you.
Madam, I
also.
shared the
Thank you,
post link in the chat box, madam. Ask
Yeah.
anyone to click on the link and answer all the questions and submit.
Yeah.
So that we can issue the certificates to them.
And there is one post-test form also. So how will
That's
we
what.
get
If you
access
click
to
on the
that?
link, I've posted that link in the chat box, madam. If you click on the link, you will be
Okay.
redirected to the post test and feedback.
So we can do it later, or we have to do it right now?
You can copy that link, madam. You can do it later also.
Okay, so all the participants, you can fill the post-test form later also at your leisure time. And please do it. Otherwise, you will not get your certificate.
Yeah. Thank you, Gurpreet, for that wonderful presentation. Thank you, Shalini, Lavina. Wonderful session. And we learned so much from this session.
Yeah.
Thank you.
Thank you. Thank you. Thank you so much, everyone. Everyone, please take note of the post-test link. I hope everybody has seen the post-test link in the chat box. Hello?
No.
Yeah, Shalini, we are doing it.
Yeah, everybody has got the access to the post-test link?
Yes.
Yeah, so please fill it at your leisure time and do post it. Thank you all so much. Now, shall we end the meeting?
Yeah.
With all due regards to all my seniors, Dr. L.K. Pandey, Dr. Sulekha Pandey, ma'am.
Thank you.
And
Thank you,
Dr. Anuradha Khanna, ma'am. Dr. Ritu Khanna.
Thank you.
Thank you all so much for joining.
Shalini.
Thank you. Thank you all for
Lavina.
joining. Thank you.